We're live in 5, 4, 3, 2, 1. We're live, sir.
Okay. Vamsi, can I start?
Yes, good evening. Welcome you all for the KOA webinar on disorders of forearm access. First, our president of KOA, Dr. Chandrashekar, will do the welcome address. So please do it.
Good evening. Good evening, friends, KOA members, faculty, and senior orthopedic surgeons. We have come to the year end, and also this is our last webinar of my tenure. We had lined up many excellent webinars in the past few months. Almost this KOA webinar, we have finished about 6 to 8 KOA members, apart from PG courses. To end it in a big way, we have another excellent program on disorder of forearm axis. Injuries around forearm are the commonest. Everybody knows this. Most routinely performed surgeries. Some forearm injuries can be disastrous if you don't manage properly. So we have distinguished faculty, international, national, and from our state. They are going to teach us how to deal with these problems and how to come out with a good results. Among the speakers, we have Dr. Shantaram Shetty, a senior most professor, still is active in his profession and he is very active in teaching academic activities. And he is a teacher. Even if I studied under him, I did a DRTO from his professorship. He is a teacher from Mangalore, that is from Karnataka. He needs no introduction. I think whoever is here knows, everybody knows him. And we are fortunate to have Dr. Shantaram Shetty. 1 minute. 1 minute. Sorry, interruption for this. We have Dr. Chaitanya Mudgal. He is associate professor in Harvard Medical School, Boston. Proud to know that he is from India. His field of interest is hand surgery. I think he is going to speak a lot about hand surgery. I think that will help us to know something in detail about hand surgery. Dr. Julie Adams is a professor of orthopedic surgery, University of Tennesse, College of Medicine, and she practices surgery of the hand and upper extremity. She is here with us, and also she is going to share all his experience and knowledge with us, and we'll all going to listen to her. I warmly welcome all these big teachers and speakers. In addition, we have expert from Karnataka, Dr. Mruthyunjaya from JSS Medical College, Mysore, Dr. Lathesh from Mangalore, Dr. Kannan from Osmet, and Dr. Vamsi. He is also hand surgeon, a microvascular surgeon, got trained in Japan. He is going to coordinate and moderate this session. And Dr. Satish, Joint Secretary, I thank Dr. Satish especially for organizing all the webinars in this year during my tenure. Because this is the last webinar we are conducting, I thank you very much, Dr. Satish Sarvekar. And I thank you everybody for attending these webinars virtually. And it's a very successful webinars. We had webinars in a good field, and we really thank all the organizing people, Dr. Vamsi, Satish Sarvekar, everybody responsible for these webinars. Dr. Vamsi, please take over and go ahead with the moderating the session. Thank you. Thank you very much.
Thank you for the welcome address, sir. Before we move on to the talks, I would like to introduce our master faculty. So as Dr. already told, Prof. Shantaram Shetty, who is a well-known face among orthopedics in India. He's a pioneer orthopedic surgeon from Mangalore. I think he has educated generations of orthopedic surgeons while he was at KMC, and he continues the same even now at Tejaswini Hospital. He was a president of Karnataka Orthopaedic Association in 1985, and that was when I was born, and president of Indian Orthopaedic Association in 2009. He is currently the pro-chancellor of Nitya University, and he also heads and runs Tejaswini Hospital, which is a busy orthopedic center in Mangalore. And he's a recipient of numerous awards for his various contribution to the society. I welcome you, sir. Next speaker will be Dr. Chaitanya Mudgal. He's a well-known and world-renowned hand surgeon. He's familiar to all our Indian orthopedicians and hand surgeons for his various contributions. Dr. Mudgal is an expert upper extremity surgeon from Massachusetts General Hospital, which is a part of Harvard Medical School. He's currently the chair of AO Trauma Hand Education, and he's doing a tremendous job in conducting AO webinars weekly, right from basics to advanced level for the past 2 years. Dr. Mudgal, in addition, he conducts a yearly Indo-US hand surgery conference at various parts of Karnataka, and he's been doing successfully for the last 5 years. He's also a part of Tara Foundation Trust that helps scholars from India to visit Harvard Medical School for a short duration. Thank you for doing excellent work, sir, and we welcome you to this meet. So, Prof. Julie Adams is from University of Tennessee College of Medicine, Chattanooga. So before joining there, she was a professor at the Mayo Clinic, Minnesota. She specializes and practices in the surgery of hand and upper extremity. Apart from her training in Mayo Clinic, she received additional training in hand surgery from Philadelphia Hand Center. She's a very active member in NASH. Whoever follows her knows her well. She's also serving as a Council of Education for the AOS, as a chair of Hand and Wrist Content Committee, and as a president of ASH Hand Surgery Endowment. She has contributed a lot to the orthopedic and hand surgery literature. I welcome you, Professor. So along with them, I also welcome my co-panelists, Dr. Mruthyunjaya, Dr. Lathesh, Dr. Kannan. So over to you, Dr. Professor Julie Adams, on your first talk, which will be on biomechanics of forearm.
Thank you very much for that kind introduction, and thank you for inviting me to participate. Please, can you see my screen?
Yeah, please. Yes, sir. Go ahead.
Perfect. It's such a pleasure and an honor to be here with you. Certainly, in many ways, the world is further apart with the pandemic, but it's nice to have the opportunity to gather, at least virtually. My task is to talk about disorders of the forearm axis and longitudinal instability. And we all know about the contributors to axial stability of the forearm. The radial head and the radiocapitellar joint is a primary stabilizer. And then we think of the TFCC and the interosseous membrane as secondary stabilizers. When you think about the interosseous membrane, there's several consistent portions. The central band, which we think is the most important contributor to longitudinal instability of the forearm, is very consistent across patients. There's also a distal oblique bundle that's quite important for DRUJ stability and has received attention recently in the literature. We call it a membrane, but the reality is that it functions more as a ligament, as I'll talk about in a bit. It traverses from proximal radial, the distal ulnar. It's about 1.5 centimeters wide and fairly thin. And it's located about 60% of the length of the radius from the styloid, and then runs to about 1/3 up the ulna from the wrist. Again, we talk about it as a membrane, but in reality, it's more akin to a ligament. It's mostly collagen. It has ordered fibrils, and functionally, histologically, it acts as a ligament, as described by Kozin and colleagues. When we think about longitudinal instability of the forearm, the Essex-Lopresti lesion, we think about injuries to the wrist, the interosseous membrane, forearm, and elbow. And this can happen acutely, or it can subsequently present after an acute injury with attrition of structures over time. Although we call it an Essex-Lopresti injury, he was not the first to describe this injury. In 1931, Brockman and colleagues described 2 cases of axial instability following radial head excision. And in 1946, Kerr and Co. described an acute instability pattern. We associate this injury with Dr. Essex-Lopresti. I guess it's Mr. Essex-Lopresti, since he was a surgeon from the UK. And he died tragically at a young age, but his colleagues collected 2 of his cases and published them after his death. And these were originally described as a fracture of the radial head and a dislocation of the DRUJ. He didn't actually recognize the interosseous membrane or the forearm injury. And I think it's worthwhile to look back at the article. Sometimes we don't do that when they're very old articles, but this was 2 cases. One was a coal heaver. He had an axial injury to the forearm, no wrist pain initially, had this radial head fracture. The radial head was excised. And then subsequently they noticed that, oops, something went on at the wrist, and he had radiocapitellar impingement. They attempted traction and reduction. That didn't work. And despite the radiographic and clinical appearance, the patient ultimately did well. And this is the kind of patient I want in my practice. He was the type of patient that would get a good result after any injury. They recognized this, and so had their antenna up looking for types of injuries. The second case, a gentleman falls from a ladder, wrist and elbow pain, radial head was fixed with suture, and he developed some post-traumatic arthritis and then was still able to return to work. So again, we now understand that in addition to the wrist and elbow injuries, there's a forearm injury. And the treatment strategies are predicated on recognition. Lee Osterman, who probably has the biggest world experience with Essex-Lopresti injuries, found that out of 106 referral cases, the diagnosis was made in just over a third. At the Mayo Clinic, the diagnosis was delayed on average almost 8 years. And part of this is patients may not complain of wrist or forearm injuries. There's the distracting injury, the more obvious elbow injury, the physician may not examine. So to avoid missing these injuries, I think that when you see a radial head fracture, examine the wrist and the forearm, consider imaging of the wrist, the old principle of examining a joint above and below the obvious injury. If there's no forearm instability, you're not out of the woods. Treat the radial head fracture. If you're planning on excising the radial head, you may want to perform the so-called radial pull test. Also, Professor Mudgal described lateral displacement of the radius after radial head excision as a mechanism to diagnose instability of the forearm. If you see that, you need to have a high suspicion for forearm instability and be aware that you should not simply excise the radial head. You're going to want to replace it and potentially do something to the forearm to stabilize it. So again, examining a joint above or below. This is a patient of mine, had a radial head fracture. He did not complain of wrist pain, but did have some tenderness at his wrist. So here's his imaging of the wrist. So be very careful and cautious of that. Again, specifically examining the patient at the wrist and the forearm, consider going ahead and getting imaging. Some folks talk about getting an ultrasound or MRI. It really depends on technique for ultrasound. MRI is often very difficult to interpret. And so I think relying on your physical exam and some of these ancillary studies, Smith and colleagues described the radial pull test. If you're replacing or excising the radial head, once the head is out, if you're thinking about simply excising it, placing traction, and then fluoroing at the wrist, if there's excessive mobility at the wrist, then you know the interosseous membrane and the TFCC is disrupted. Dr. Mudgal and all described lateral displacement as a highly sensitive test in both extension and supination and inflection and supination. So I think the issues when you treat these injuries are is it acute or chronic? And you need to consider the wrist, the forearm, and the elbow. We do know from the Mayo data that early initiation of treatment is more likely to result in a satisfactory outcome. We think that when it's in a chronic setting, that perhaps the ability to have restoration of more normal anatomy is altered. And the strategies really at the elbow, ORIF versus radial head replacement, at the wrist, repairing the TFCC and stabilizing the DREJ, and at the forearm, there's still ongoing discussion about what the optimal treatment, if any, is for that. Some folks have described immobilization, and I think that in most cases, this seems to be inadequate for healing of the interosseous membrane, immobilization with cross pinning. Direct repair has been described. I think that it's very challenging. It's difficult to repair this structure. And you think about the interposed muscle as something that keeps herniating through. Augmentation has been described. The group from Wake Forest has described use of a pronator graft. I've done this. It's fairly easy and straightforward. You take a strip of the pronator, you leave it attached to the radius, and then you rotate it and place it distally. Here's a patient of mine. This is a 49-year-old woman. She was riding her bicycle, was struck by a car. Here's her wrist and elbow x-rays. And I think that when you look at the elbow x-rays, this is a pattern that you should be able to recognize. The radial neck is basically driven up into the head and is almost excavated, the radial head. So despite her relatively young age, this is very difficult to fix because essentially the radial head has been excavated of all marrow and structures. And this is one that you're very concerned about, an Essex Lopresti lesion, and had a distal radial ulnar joint disruption as well. So I replaced her radial head and did the pronator graft. And ultimately, here she is preoperatively, and here she is postoperatively, and she did quite well. Reconstruction has been described with a lot of different structures, some of the same structures that are used in the acute setting. And I think that the position you want to avoid is having this chronic radiocapitellar impingement and ulnar impaction at the wrist. In the chronic setting, you have to deal with the radiocapitellar pain as well as the wrist pain, but also there's some discomfort in the forearm that patients often have. Typically at the wrist, we do a joint leveling procedure, usually an ulnar shortening osteotomy. And at the radial head, at the elbow, a lot of different treatments have been proposed. We know that silicone prostheses do not seem to have sufficient axial stability. Allograft has been proposed and has not so great results. And then metallic radial heads. The problem with metallic radial heads is some patients continue to have some axial instability and loading. And we know that the capitellar cartilage is not normal, and patients may have continued elbow discomfort. The forces on the radiocapitellar can be problematic. And again, when you place this radial head, it's not going to restore the contact forces to the normal. In the United States, we used to have this implant that I've used before and I liked quite a lot. It was withdrawn from the market. I know that there are similar implants available in other parts of the world that have been described. And I think that this is a reasonable option for patients with radiocapitellar pain and impingement. And it has had some decent results for this indication. At the forearm, a variety of different techniques to restore stability. Bone patellar bone tendon seems to closely reapproximate the native IOM. I like this for the chronic setting. I usually do a wrist scope, TFCC debridement, joint leveling procedure, and then do an interosseous membrane reconstruction. This is tunneled underneath the extensor tendons, which is kind of problematic. If you think about it, there's not a whole lot of space under there. And so you can have extensor adhesions. The patient can be irritated. You have to be careful. You're coming out at the bare area of the radius, and just watch out for the superficial radial nerve. I usually make a little trough and then place a screw into it to secure it. Lee Osterman and his group reported on the outcomes of this using either allograft or autograft, and found a high rate of improvement of wrist pain. Early on in the series, they were using autograft and abandoned that due to knee pain, and found good results with the allograft. More recently, Gaspar and colleagues published on the Philadelphia experience in 2018, 33 patients, mean follow-up of almost 11 years. And they brought these patients back, all but 2, and found that ulnar variance, there was an initial increase after surgery, but post-op, it seemed to be well maintained. There was revision surgery in about a third of patients. Many of these patients were related to ulnar shortening hardware or non-union. The thing that's received more attention more recently is suture button reconstruction. And again, this is from the Philadelphia group, using suture button constructs in 10 patients with chronic Essex Lopresti injuries, and similar pattern of passing the graft, except this goes along the axis of the interosseous membrane. It's much less bulky, and so you're not likely to have the extensor adhesions or irritation that you might with the bone patella tendon bone. Again, about a third of patients required additional operations. So I think that the take-home message is, whatever you do, telling your patient that the story may not be over. You're likely to need additional interventions over time. One patient had a fracture through the drill hole. I've seen this with other techniques as well. And ultimately, she had ORIF and fixation. Another patient had limited forearm rotation. You can possibly put this too tight, so be careful and cautious about that. One of the newer ideas is using 1 versus 2 tightrope devices. If one's good, 2 must be better. Again, when we think about the interosseous membrane and dealing with these patients, trying to restore longitudinal instability or longitudinal stability to the forearm can be quite challenging. And so you think about, can I put 2 and have 2 points of fixation? If you look at that, the 2-button construct has better resistance to migration. But again, you worry about forearm rotation here. So in summary, we know that Essex Lopresti lesions results from axial loads to the forearm. And these include injuries to the elbow, the interosseous membrane, and the wrist. You really have to have a high index of suspicion, going in very, very suspicious that the patient may not just have a radial head fracture, they may have something else, and really specifically examining them and obtaining appropriate imaging. Instability can present acutely, like the patient I showed, the bicyclist, or over time. So simply excising the radial head, you're going to watch these patients. And treatment is aimed at each site. Thank you very much for the honor of being with you today. And I'm so excited to hear the other speakers' talks as well.
Thank you, Professor Judy Adams. Do you have any questions from the panelists and co-speakers? Anybody? We can have Prof. Dr. Judy Adams. Do you routinely recommend to get a wrist X-ray in all cases of radial head fractures?
I'm sorry, my audio cut out for a second.
Do you recommend getting a wrist X-ray in all cases of radial head fractures?
If the patient is absolutely non-tender, I think it's not unreasonable to defer wrist x-rays. If the patient has any tenderness at all, if they have an x-ray like the one I showed where the radial neck is basically abutting the capitellum, then I will get that. If you think about radial head fractures, there's pretty good data and that you replace the radial head over time, there is still a change in ulnar variance. In the non-longitudinal instability of the forearm, it sort of stops over time. The problem is when there's this gross instability that it stops.
Do you want to talk about something called reverse Essex loop resti? How is just for the audience?
So
Commonly,
can you clarify what you mean by that?
I don't know, I've just not come across, but I think there is a distal fracture or radius fracture, and there's a proximal instability at the PRUJ.
Yeah. So the PRUJ also has a contribution to stability from the proximal radial ulnar joint, has contribution of stability from the IOM. And I have seen some patients in which there is interposition of soft tissue. So if you think about trying to reduce the radial head and you're not able to get that back in, I often think about, is there something blocking my rotation? Not related to a reverse Essex Lopresti or another injury. Is I've seen patients herniate their radial head through the brachialis and have it wrapped around. The literature has some case reports about wrapping around the biceps tendon. It may actually be the brachialis that it's herniating through. So I think that, again, if you're having trouble reducing the radial head, thinking about if there's interposition of soft tissue, and some of these patients can be very, very difficult to.
Thank you, Professor.
If there's a fracture there, fracture of the radial head, so where we will not be able to make out the height of the radial after reconstruction. So is there any clue or is there any method by which we can know how is the height of the radial head maintained?
Yeah, that's a great question. So if you have a radial head that's sort of blown to smithereens and you're trying to replace it in terms of sizing, I tend towards undersizing. I think that if we have gross instability of the elbow, the temptation is to restore stability by so-called overstuffing the radial head, and that can be very problematic. So in the acute setting, if I'm doing the case initially, I'll try and assemble everything on the back table to see what the native radial head size was and try and go off of that. Another trick that some folks will do is get an x-ray of the other side and try and replicate the sizing there. If you look at the PRU and you look at where the coronoid is, you want to be within a couple of millimeters of that. I think the real challenge is if you're in a situation where somebody else has excised the radial head or the native radial head is no longer there, you're trying to figure out, is this the right size implant or not? And the elbow is grossly unstable. The temptation, again, is to overstuff it and, oh, now it's stable. But that's something that should be avoided because those patients inevitably sort of grind away of the metal versus the capitellum, and it also overloads the medial side of the joint there. So being very careful, looking at the PRUJ and making sure that you are able to do a reconstruction or repair of the lateral side of the ligaments to help restore stability. If there's some coronoid fracture that's conferring instability, that you've also addressed that.
Yeah, thank you.
Thank you, Professor. Do you have any questions from the panelists, or should we go with the next talk? Prof. Gilead will please stay back for the case discussion. So we'll go with the next talk. Time being. Our next talk will be by Dr. Chaitanya Mudgal on proximal complex ulnar fractures. Please go ahead, sir. I will make you a co-host in a while. Oh, yes, sir. Okay, good to go.
Good to go. Okay. All right. Are you doing okay here?
Yes, good.
Okay. So, good evening, everyone, and thanks to all the organizers at KOA, and it's really an honor to be part of this panel with all of you, and it's really nice to see all of you. I missed my visit to Karnataka this year, but we'll be back again next year. Julie and Professor Shetty, it's also great to see you guys. So let me start off here with this late 40s, early 50s medical professional who fell from a standing height and presented with this. This is was seen by another surgeon, and this was done. And at first sight, it appears that things are okay. But if you look closely, are they really? Radiocapitellar contact doesn't seem like it's been restored. There's something going on there which is not quite right. And then when you look at the anterior portion of the proximal ulna, the coronoid assembly doesn't look right, and the anterior cortical buttress also doesn't appear to be restored. Regardless, this was what was accepted by the surgeon. And when she came back 2 weeks later, it was not surprising that this is what had happened. In a splint, mind you. So the question we have to ask ourselves is, could we have foreseen this? Was this predictable? Was this avoidable? And which is what I'm going to talk to you about, complex proximal ulnar fractures and the influence of anatomy on fragment geometry and surgical tactics. Because it's really, a fracture which is basically a pathology, and it's really anatomy gone wrong. So if you know your anatomy, you can predict fracture geometry and therefore fix it accordingly. Although most of the material in this talk is mine, I must acknowledge the help I've received from these sources. So why do we think proximal ulnar fractures are complex? Well, for one thing, it articulates with both the forearm and the elbow. Its uniquely subcutaneous position makes it vulnerable to direct trauma and also makes the soft tissues very unforgiving, as you'll see in some of the patients I'll show you later. Now, what happens is we tend to think of the ulna as a straight bone, but obviously it's not. It has proximal ulnar varus and a proximal ulnar dorsal angulation, which therefore confers upon the proximal ulna a compression side and a tension side. And you have to take that into account when thinking of which side the combination might be. We know that combination is usually more frequent on the compression side. So if we think that way, we already know where the fracture lines are going to generate. And then, of course, you have the unique ligamentous anatomy, which predicates fracture geometry and stability. And why is that? Because we know that where the ligaments are attached, such as seen here, as seen by Greg Bain's studies on the distal radius, we know that because of Wolff's law, in this attachment location, the bone density is higher. So also, when you look at here, so we looked on the medial side at the sublime tubercle and on the lateral side at the supinator crest. It's not surprising the bone density in these locations is higher. And when you look at the picture on the extreme left, you see the bare area of the proximal ulna where you don't have any articular cartilage, and that area measures between 5 and 6 millimeters, and the amount of subchondral bone is less. So what we know now is that there are strong zones and there are weak zones. The weak zone being the bare area of the proximal ulna, and the strong zones being the points of ligamentous attachments. Therefore, your fracture lines will predictably generate between these areas. What does that mean? Well, let's look at this. The proximal ulna, the olecranon, stops anterior translation, whereas the coronoid stops posterior translation. And the curvatures are the points of increased bone density. Therefore, your fracture lines will generate in between these curvatures. We'll see that in just a second. But are all these fractures the same? Of course not. If you look at some of the data on these fractures, it appears that fractures in women, irrespective of age, tend to behave more like fragility fractures, whereas fractures in men under the age of 50 behave more like a young bone fracture and tend to require a higher degree of trauma, whereas in men over the age of 50, once again, they tend to behave more like fragility fractures and can occur from simple things like falls from a standing height. So Gill and colleagues, they did a quantitative CT of 9 cadavers, and they found that they calculated bone mineral density was highest at the olecranon tip, at the anterior coronoid, and the subchondral bone. All things that we would expect. Therefore, it goes without saying that you would get better fixation there, and it's unlikely your fracture lines will generate there, or if they do, they'll be part of comminution. Now, as I said before, there is dorsal angulation, which varies depending on which study you read and which country it comes from, which is about 4 to 6 degrees, sometimes up to 14 degrees, and it usually is at about 26% the length of the ulna as calculated from the tip of the olecranon to the ulnar styloid. Similarly, the varus angulation is approximately the third of the length down the ulna and usually varies between 8 and 28 degrees. So if you look at this, you can see that here you have the dorsal angulation. Therefore, if you have a fracture line that generates from your bare area where the subchondral bone is weaker, it is not surprising that the fracture line would exit on this apex and it would compress here, and therefore you should expect to get a quadrilateral fractured plate here, as shown by Jupiter way back in 1991. So these pictures show the proximal dorsal angulation and the apex of the proximal dorsal angulation, and the tip to apex distance is about 8 centimeters. Similarly, here's the varus, which you can see here, and therefore you can expect comminution on the medial side and a tension failure on the lateral side, or a blowout of the lateral cortex at the point of attachment of the ligaments to the supinator crest. What does that translate into when we are assessing fractures? Based on my own data, which is as yet unpublished, and the published data from Fujihara, we know that fracture lines predictably will go from anterior proximal to dorsal distal, from ulnar proximal to radial distal, as you can see in these pictures. There will be a large anterior fragment for the reasons that I just outlined to you because of proximal ulnar dorsal angulation and the compression and tension forces. If there is a lateral blowout of the supinator crest, it goes without saying almost always that there will be a comminuted radial head fracture. The coronoid fragments can be variable depending on the degree of shearing. If there is a medial blowout, it almost inevitably involves the anteromedial facet. As you can see here, you can see that there's a medial fracture and extending into the anteromedial facet, and there's a lateral blowout as well. And this CT emphasizes all the classic features that we just talked here. You have your fracture line running from anterior proximal to dorsal distal, from ulnar proximal to radial distal. You have your lateral blowout, you have comminuted radial head fracture, all the classic features that you can expect to see repeatedly, consistently, and reproducibly. So, now that we know how the fractures occurred, how are we going to assess them? Well, I find that plain X-rays are notoriously inadequate because they undercall comminution, and therefore I use CTs very liberally, and I find that 3Ds are far more useful. I do a prompt close reduction in dislocations only. If there's no dislocation, I don't think there's any utility to trying to do a close reduction. You have to alert the patient to the severity of the injury. And if you have reduced a dislocation, you have to be mindful that redislocation, as I showed you in the first case, can occur within the splint. I usually get a post-reduction X-ray and a CT with and without reconstruction, 3D reconstruction with subtraction of the distal humerus. So how do I look at them? I look at them as simple and complex. Simple fractures are these fractures, two-part, going through the bare area or avulsion of the triceps, which are really simple two-part olecranon fractures which can be fixed quite easily. The complex ones involve joint depression, and they might be proximal as well as distal comminution, and they may have no elbow dislocation or they may have elbow dislocations. First, we are going to look at those without elbow dislocation. And what do we try to do to them? You want to make sure that a stable, congruent, and concentric joint, even if somewhat stiff in my assessment, mind you, this is my assessment, is still vastly superior to a fully mobile but unstable joint. So you'd have to decide that you want a stable concentric and congruous elbow. You want to restore the anterior buttress so that the posterior dislocation doesn't occur in the case like in the case I showed you before. You want to restore radiocapitellar contact, which was not done in that case. So either you repair the radial head or replace the radial head, repair the lateral structures. You must check stability before you leave the operating room. And if the fracture is older than 10 days, I routinely release the ulnar nerve. You want to make sure the skin doesn't look like this, because if it does, then you should absolutely wait to operate on this patient until all the blisters are gone and the skin looks healthy. Now, this is not a small abrasion on the picture on the right. This is a full thickness skin injury. And if you operate through this, it will break down for sure. You also want to get a good exam of the ulnar nerve. I tend to position my patients in the lateral position with a bean bag, as you can see here. The blue arrow shows the protection of the axilla. This blue arrow tells you about protection of the breasts and the nipples. This red arrow is, you have to be mindful, especially of the genitalia. And finally, this light blue arrow tells you to be mindful of the common peroneal nerve to make sure there's no pressure on it. I use a standard posterior incision, and I make sure I mark my lateral and medial sides to keep orienting myself constantly. What do I keep in the operating room? I'm going to leave this on the screen for a couple seconds. I don't think I need to read it. But this is usually what I keep for a complex proximal ulnar fracture. I keep the titanium plates, LCDCPs, as backups in case we have difficulty with the contoured available plates, and I usually have the modular hand set in case I need to put orthogonal plates. So here we are. This is a young man who fell from a standing height, although he was doing something sportingly involved. And this seems like a simple two-part fracture, but is it? You look at the X-ray and you can see that the joint is quite significantly depressed here, and the proximal fragment is very small, and your fracture line is running exactly the way we said, proximal to distal, dorsal, and proximal ulnar to radial distal. Now, again, we have to remember the proximal ulnar varus, and therefore your wires should take into account, if you're going to fix it with a tension band, your wires should be directed a tad more straight or a little more ulnarly. So what are the principles of tension band? I use 1.6 millimeter wires, and if you are one of those people who believes in engaging the anterior cortex, then the angle between the long axis of the ulna and your wires should be about 30 degrees. So also this angle between the long axis of the ulna and this direction should be 30 degrees so that you do not impinge on the radial tuberosity, on the bicipital tuberosity of the radius. Now mind you, engaging the anterior cortex is ideal and it's great to avoid pullout, but it's not mandatory. The key is you really don't want to narrow the notch. You always want to place these wires with the forearm in supination so that you don't inadvertently drill into the bicipital tuberosity, and always check forearm rotation when your fixation is done. So here we are, we elevated this depressed fragment and we templated it to the trochlea, we grafted behind it and then fixed it with a tension band. I tend to use 2 figure of 8s, and there you've restored anatomy. Now if you notice, there's another tension band here because there was comminution right here. In these small fragment comminutions, I use this tension band technique a lot, where I fix it with threaded K wires and then supplement it with a figure of 8. Again, this person came off at reasonably high speed off a longboard, which is a motorized skateboard. And you can see here the same exact fracture pattern with the same degree of comminution, except in this case, the comminution is articular and all these little pieces that you see here basically belong somewhere in this area. So what we did was we fixed each of those pieces with threaded K wires, and these must be inserted at low torque because they are threaded, they run away from you. So you insert them at low torque and you assemble this and convert it basically to a 2-part fracture, and then you fix it with a tension band because the prevalent fragment is so small. However, what do you do if you think that the proximal fragment is so small and there's comminution and your line of fixation has to go down the medullary canal? Well, you can look at a variation of the tension band where you must template the medullary canal of the proximal ulna and make sure you know exact location of your proximal ulnar varus. Once you know that, you select a 7.0 or a 7.3 millimeter cannulated screw with a washer, and you must engage the proximal ulnar varus. If this screw is too short, It will toggle inside the medullary canal and you will lose fixation. And then you simply attach a tension band to the whole thing and it works remarkably well. So what do we do now? So we looked at complex fractures without dislocation. Now let's look at them with dislocation as shown in these x-rays here. Now people tend to get hung up on calling them posterior montegia, an anterior transolecranon fracture dislocation, a transitional lesion which has some features of the terrible striad. I simply look at them as a continuum. These are complex proximal ulnar fractures and you want to think of them not as these names, but you want to think of them as a complex proximal fracture of the ulna, which can also have a radial head fracture, a coronoid fracture, ligament injury, or joint impaction. When you think about it that way, you are not getting hung up on eponyms, but you're treating the injury on its own merits and on anatomical generation of fracture geometry because you know the anatomy and you know where the fragments are going to be. What are the principles of treatment? You want to restore the contours and dimensions of the trochlear notch, and your plate must be contoured dorsally because that's the tension side. You want to address the radial head through the ulnar fracture. Mind you, as shown in this cartoon here, you're looking down even at the coronoid through the ulnar fracture. You want to restore this compression-resistant anterior buttress because remember the anterior cortex filled in compression, giving you that quadrilateral plate that Jupiter talked about 30 years ago, but which has an anatomic basis based on attachment of soft tissues. You want to restore that also through the ulnar fracture and get 8 cortices distally if possible, and always proceed from deep to superficial. So here we are. Let's look at this young lady. Now, how do you characterize this fracture? This is a complex proximal ulna, but there's also a radial head. There's a coronoid. So this is what I would have thought about as a transitional lesion between a montegia and a terrible triad. So when you put the patient in that position, as I showed you, you can literally take the forearm and sublux it towards you, and it allows you to look directly down at the radial head, and replacing the radial head is really very easy. So we did that, and these holes that the red arrow is pointing to is the stay sutures that I took in the coronoid piece and then brought them out in this manner. Now it is important to know this, and I'll come to that in the next set of slides, but here it is. Once you predictably restore anatomy, you got your quadrilateral plate restored here, you can expect an outcome that is fairly reproducible. So here we are at the coronoid. Now remember I showed you those holes. Those holes are doing this to the coronoid and bringing them out. But you have to be mindful where these sutures come out because you don't want to drill through your sutures when you're fixing the plate on. So if you can't bring the sutures out in this manner, you bring them out on the sides as I showed you in the previous x-ray so that you don't inadvertently cut your own stitch. You tie these stitches finally once your entire bony reconstruction is done. So let's look at someone like this. Now this is a person who fell from a standing height, if I remember correctly. And again, this is a person over the age of 50, so even it's a male, the fracture is behaving almost like a fragility fracture. Now in this case, it was very difficult to fix the comminuted coronoid with the help of the suture. So we use these threaded K wires. You can place them through the fracture, you can drill them at low torque, and they help to hold it. And you can cut them within the fracture so you don't have to worry about them. And there he is. His outcome looks reasonable, but most of these patients will lose a little extension and a little terminal flexion, about 10 to 15 degrees in each direction. What do I do about the blowouts? Well, here's a person who had this blowout. You can see on both sides, you have the anterior quadrilateral plate. Now, remember I said in the patients over the age of 50, they behave more like fragility fractures. So there is this temptation to fix these fragments with interfragmentary screws. I have gone away from doing that in the older patient, and I tend to use this tension band technique. In the young person with hard bone, yes, you can use interfragmentary screw fixation. But in the older person, I've gone to using these tension bands, as you can see here with these wires. These are threaded wires. I place them, and I simply add a figure of 8 tension band to hold it. It is low profile. It does not violate any principles. In fact, it reinforces principles, and it allows you stable fixation. So here, this is how the construct would look when you restore your blowouts back together with very stable fixation. And you can get a very predictable and reliable and consistent outcome. In the presence of comminution, you have to be prepared to go long. So normally if you go 6 to 8 cortices distally, maybe go a little longer with the plate. So here's this person who was trying to catch a high fly ball, and in trying to catch it, he caught the ball, but he ran into a tree. This is a young person, so this is an extremely high energy injury. And you can see from the degree of comminution and the generation of these fracture lines that these fragments are completely expected. I knew when I went in there that this is what I was going to see, because that's what we know happens. So here we are with a long plate, and I'm showing you these tension bands which have been put back together for those fragments, in addition to also using these interfragmentary screws. And you can get, again, like I said, a very predictable outcome. This plate shows you conformation of the proximal ulnar varus. So how do I address the anterior anteromedial facet? Again, look at the quality of this bone in this lateral X-ray. It's very osteopenic, and trying to address the anteromedial facet with a plate can be remarkably challenging for me. Therefore, I resort to these threaded K wires and the use of a tension band. Oftentimes, I will use the second plate from the modular handset from a small fragment set merely to provide a secondary buttress as you restore the dorsal side. And if you have extreme comminution, now this is a case of Dr. Jupiter's, and this is a wonderful trick to know. You use the large fragment distractor from the femoral distractor set, and you put one Shan spin up the humerus and one in the ulna, and as you distract it, let the soft tissues pull the fragments back into place and merely bridge the entire construct. You can graft as necessary. And here's this patient with a very reasonable outcome. Now, finally, I'm going to give you some special considerations that we come across here in this country, and I don't know how many of these you'll see in India. But patients who are fairly large. Now, here's this person who weighs anywhere between 280 and 300 pounds, and he is just muscular and very stocky. He's not, So this is a high energy injury because he fell from a height of about 15 feet. You can see the comminution, and the fracture geometry is exactly what we'd expect. So in him, what are the challenges? The first challenge is positioning the patient. So this positioning must be done very, very carefully. And in these situations, oftentimes we'll position the patient first while they're awake, and then our anesthesiologist will place the laryngeal mask with the patient in the lateral position. So the patient positions themselves, and the surgeons don't expend energy trying to position this patient. The other thing is deciding on the hardware. Is it going to be able to take the weight of the arm and the rehabilitation? If I have to be strictly critical of this construct, I would like to have gone maybe 2 holes longer. But again, you can see that I've used the tension band principle to reconstruct the blowouts, and I've got my anteromedial facet back together. And you can get this kind of outcome. Finally, I'm going to leave you with this situation where this is a young person who's morbidly obese with this posterior Monteggia, and the radial neck is fractured as well. This is an immensely hard situation. This patient weighs just over 600 pounds. So you have no hope of positioning this patient in the lateral position. So you have to do it in the supine position. So in that position, what you do is you have to work by not opening the fracture site. You merely incise the skin, and because of the nature of this fracture, you put the plate on contour. This is an old case. We didn't have pre-contour plates in those days. I use titanium plates for this reason. I can contour them easily. You put the plate on and use the plate to merely use it as a reduction tool, and it pushes the bone back into place. We did not disturb the periosteum. We did not disturb anything. And you can see the radial neck, just as soon as you restored ulnar anatomy, the radius was also restored. So take-home messages: you must restore the anterior buttress, you must restore the dorsal bow, you must restore the varus, and be mindful of where you expect to see comminution. You'll always see comminution with the anterior quadrilateral plate, the medial and the lateral blowouts, and finally, don't forget to work on the radial head through the ulnar fracture. So why did this happen? This happened because the anterior quadrilateral plate had not been restored. This happened because there was undiagnosed avulsion of the lateral complex from the distal humerus, and there was no purchase in the anterior portion of the ulna. So not surprisingly, you had no stability against posterior shear. So here we are. We restored stability on the medial side with a medial plate. We restored stability on the lateral side by fixing the LUCL. We ignored these fragments and checked stability. And it's a reasonable outcome. Like I said, they lose a little terminal extension, a little terminal flexion, but she was completely happy and back to working as a medical professional. Thanks very much. I'll stop sharing there.
Thank you, Dr. Chait. Any questions from the panelists?
Yeah, that was an excellent presentation, sir. Especially that biomechanics was quite good. So I just wanted to ask you, since you use CT so profusely, do you consider using MRI any time in your planning of to look for any?
I have never used an MR thus far, but I would not rule it out. I have not found the need for it, and I don't know how it would influence my decision making.
Okay. So regarding the ligaments and all, if you
so here's the way I would put it. I know what's going to break.
Okay.
I know where it's going to break. So once I put it back together, I make sure that I've fixed what's broken. And, thus far it's held me in good stead. So
it's quite good, sir. Well, your series has been quite good. And can you share about the post-op protocol, what you use for your rehabilitation?
Sure. So I'm one of those people who does not subscribe to the theory that elbows need to be moved right away. I think it's a reasonable concept, but I think we have to question that concept. I think the first thing you don't want in an elbow of this nature is wound breakdown, because wound breakdown will compromise everything. So the first order of business for me is to confirm wound stability and equilibrium, which means until stitches come out on day 12, I don't disturb them at all. Stitches come out on day 12, I may allow them forearm rotation from day 5, but that is done with the elbow at 90. Elbow flexion extension not unless the wound is healed. So that starts on day 12. And depending on the injury, if I'm concerned about the dislocation or it was a terrible triad or something, a transitional lesion, I will let them extend by 30 degrees a week, so that by the end of, between 4 and 6 weeks, they are coming close to full extension. Flexion is unlimited, and flexion is usually done with the patient lying on their back, so you do gravity-assisted flexion.
Okay. Thank you.
Dr. Chai, I think a lot of issues we see is the wound basins on the plate, on the olecranon. Do you have any tips to avoid this?
So you don't want to. So, like I said, wound descent is just, it kills the whole outcome. So the first order of business is don't operate until you like the skin. Waiting will not burn you, in my experience anyway. It might give you a little bit of stiffness, but it won't burn you with the skin. So you want to approach the patient only when the skin is stable and there's soft tissue equilibrium. And the other thing is, don't move them until the wound has healed solidly, which is 12 days in my opinion.
What's the role of CPR?
Go ahead, sir.
Elbow CPRs?
Say that again, sorry.
What's the role of elbow CPR? Continuous passive motion. So many
I don't use it. I have not felt the need to use it. We used to use it in our hospital many years ago, but we have. I just think the active motion works reasonably well. So.
What about the committed coronoid fracture? I think sometimes it's very difficult to put them back. I mean, I've seen some techniques describing using a radial head and the olecranon. Do you have any experience with this?
Yes. So if you're going to excise the radial head, because it's so badly fractured, oftentimes you may find that you can use a fragment of the radial head to restore the anterior buttress. And again, because you sublux the forearm back towards you, you're looking down at the coronoid. And it makes it reasonably straightforward to reconstruct it with a fragment of the radial head. You can do that. Oftentimes you find that if you just get your soft tissues lassoed with sutures, that's all that you need. And for the anteromedial facet, you're looking around the corner. So you just put a plate there as a buttress plate and multiple threaded K-wires. Again, that's more than adequate, like I showed you.
What are the sequence of fixation in such fractures?
So it's always deep to superficial. The first order of business is the radial head, because you can harvest the radial head for any other uses. Most of the time in these fractures, I find that the radial head in my hands is not reconstructible, so I don't waste time on it. I quickly replace it and move on to the harder part of the case. And then I address the coronoid, the anteromedial facet, then the articular combination of the proximal fragment. So the idea being that after I'm done with all this, when I put the plate on, I'm literally fixing a two-part fracture.
Any questions from the panelists, or should we go with the next talk? Dr. Shantaram Shetty, sir,
Yeah.
we can go with the next. Thank you, Dr. Chaitanya. Please stay back for the case discussion.
Sure.
Good evening to my colleagues and good morning to my faculty in the United States, both Professor Julie and Dr. Chaitanya. After two brilliant lectures from these two faculty members, I am dealing with a fairly simpler problem, looking into the complex fractures which Dr. Chaitanya showed so exquisitely, and the biomechanism by Professor Julie. I will go on to a simpler fracture. Gilead, what is Gilead fracture dislocation, and the forearm axis to be mentioned. Forearm drives and directs the hand. That has to be taken into consideration. Look into all these examples, whether you are typing, whether you are writing, whether you are driving, or the exquisite on drive by Kohli, or the backhand slash by that great tennis player, and the pinpoint of your pain, or the correction of your timing, all that is required by the hand. It is the forearm which drives the hand. That has to be taken into consideration. Well, Professor Julie mentioned the importance of the interosseous membrane. I will just go through so that you will understand the Gilead fracture better. The understanding of the anatomy of the both bones of the forearm is vital, where the proximal and the interosseous membrane and the distal radial ulnar joint. The annular ligament of the radius and related joint capsule allows the radial head to slide against the radial notch of the ulna and pivots on the capitulum during the pronation and supination of the forearm, which is quite vital for any fracture of the both bones of the forearm or of the radius or of the ulna. The interosseous membrane, which Professor Julie rightly mentioned, is a thin fibrous sheet, though she called it a ligament, that connects from medial to lateral borders of the radius. And the collagen fibers within the sheet pass predominantly inferiorly from the radius to the ulna, and that has to be taken into consideration. The orientation of the fibers of the membrane is consistent with its role in transferring the forearm, the radius to the ulna, and ultimately, therefore, from the hand to the humerus. So sectioning of the central band alone reduces the stability of the forearm by 70%. This has to be taken into consideration, whether it is the shaft of the ulnar fracture or the shaft of the radius fracture or both bones of the forearm. The importance of the distal radial ulnar joint is quite important when we deal with especially the Gilead fracture. Distal radial ulnar joint is a cylindrical cartilaginous joint stabilized by a complex network of soft tissue constraints, primarily components of the triangular fibrocartilage complex, the TFCC, which has to be taken into consideration. What does the TFCC contain? Many of us are confused on the TFCC. It not only just the triangular fibrocartilage, but the meniscus homologue, which is important, and the ulno-lunate and the ulno-triquetral ligaments, which has to be taken into consideration, and the dorsal and the palmar radio-ulnar ligament, and the sheath of the extensor carpi ulnaris tendon. What's the importance of the distal radial ulnar joint in this complex injuries? It contributes only approximately 20% of the total joint stability. This joint complex acts as a support for the carpus and a stabilizer of the ulnocarpal and distal radial joints. It also contributes to the load between the ulna and the ulnar part of the carpus and permits forearm rotation. So gentlemen, forearm acts as a ring with these three important components, and once distributed can cause a functional disability, which disturbed, it can cause a functional disability which will be difficult to repair later, as Professor Julie was rightly told. So catch it early. It is vital that is not only the length of both bones of the forearm and the radial curvature are to be maintained, but also the anatomical stability of these three joints. It was Sir Ashley Cooper who first described this Gilead fracture way back in 1822, though it was later in 1934 that Professor Riccardo Gilead presented the mechanism of incidence and management of this injury. It's quite interesting that Giovanni Battista described the Monteggia fracture nearly 90 years ago, and they both belong to the same University of Milan. And if you go through the history, except these two Italians, very little Italian names come in a fracture disposition. What is Gilead fracture dislocation? It is to be defined as a fracture of the, I would call it a fracture of the distal 1/3 of the radius and dislocation or subluxation of the distal radial joint, and not the middle third as such. And that is the classical site of a Gilead fracture. And not disease, though this is almost, it depends on the height of the patient and the level of the fracture. And that is a classical Gilead fracture dislocation. The epidemiology, 7% of all forearm fractures in adults, bimodal incidence with the highest occurrence in young males and elderly females. Children incidence is 9 to 12 years, and the instability of the distal radial joint is variable. And if radial fracture is less than 7.5 centimeter from the articular surface, the instability is up to 55%, whereas if it is more than 7.5 centimeter, it has been established by biomechanical studies that the instability is only 6%. Mechanism of injury is usually due to indirect trauma, and it depends on the pronation, whether it is the flexion injury or an extension injury. And that is the classical form. And the presentation usually pain, swelling, deformity, tenderness at the fracture site, forearm movements and the wrist movements are painful. And the inferior radial joint tenderness and instability has to be taken into consideration. Always test for the sensory branch of the radial nerve and distal pulsation and functions of the hand. Coming to the X-ray, a forearm AP and lateral view, I always take an oblique view, understand this fracture much better. And that is the classical picture which you get, whether it's the dorsal angulation or a volar angulation. And the most important is how far the inferior radial joint has subluxated. And that you see the way up the distal radial joint has completely subluxated, may be associated sometimes with a fracture of the ulnar styli. The classification initially was based on the radial displacement, dorsal or volar displacement. And we classified, and this rating ME and Raskin classified as type 1, depending on, less than 7.5 centimeter from the articular surface of the radius. And with, as I told you, with the distinct significant instability, 50% in 50% of the cases. And if it is more than 7.5 centimeter, the instability will be less. But we must understand 7.5 centimeter in an American giant is not comparable to an African Bantu. African Bantu, the length of the whole radius may be about 10 centimeter. So this is not a very good classification. We classified on our own the type 1 undisplaced inferior radial joint and partially displaced radial joint and totally disrupted radial joint as type 1, 2, and 3, and we published it. And this is the type 1, and this is the type 2, and this is the type 3, where there is a complete disruption of the inferior ulnar joint. Whereas the AO has come out with its say classification with the classical, the typical A1 and A2 and A3, depending on the type of the fracture, and B1, B2, and B3, and again C2 and C3 fracture, depending on the combination and whether it is segmental. And that is the one. But the most important factor in Gilead's fracture is the signs of disruption of the distal radial ulnar joint. And that has to be taken into consideration for your treatment. Whether there is widening of the displacement of the distal radial ulnar joint in a PA view, whether there is a fracture of the ulnar styloid, whether there is dorsal or volar displacement of the ulna in the lateral view has to be taken into consideration. You would appreciate that that ulna has really displaced posteriorly and medially. And whether there is the radial shortening, which is greater than 5 millimeters. And look into that fracture, which is way up, and there is a complete dislocation. How to assess the distal radial ulnar joint? Various tests have been described. Because the postgraduates are also there, I just put this slide. The stress test, which is a ballotment test, and the radius pull test has to be taken into consideration. And the tongue test, the compress the ulna to the radius during passive pronation and supination. And the ECU test, the elbow flexion 90 degrees, hand in ulnar deviation, active pronation and supination. And the press test, where the patient pushes himself up and sealed position with the use of affected wrist. What is the treatment? Treatment is simple compared to the complex fracture which Dr. Chaitanya showed. Here is a very simple fracture. Most of these fractures are transverse fracture. And what is important is simple plating and anterior plating, with the volar plating to be undertaken, either a 7-hole or an 8-hole plate, with a K-wire fixation for the distal radial ulnar joint. The approach is Henry's volar approach, and classically the implant is 3.5 DCP or 3.0 LC-DCP or 3.5 LCP now. I firmly believe there is, and I have to emphasize, especially in India, many times we see this fracture being treated with intramedullary nails, and there is no role whatsoever for an intramedullary device for this fracture. And I re-emphasize this particular fact. Well, coming to the treatment again, after fixation of the radius, check the distal radial ulnar instability. If distal radial ulnar joint is stable following internal fixation, you immobilize it. I always immobilize it in supination for 3 weeks so that the inferior ulnar joint is stable and there is no possibility of a subluxation later. And if the radial ulnar joint is reducible but unstable following ORF, the cross-pin ulnar to the radius, and it is to be kept on for 4 to 6 weeks. And you can put either 1 pin or 2 pins after the internal fixation as you see it there. And that is a classical case which we see, whether you put it through the inferior ulnar joint or you put it is still debatable. And we try to put 2 pins always so that it is much more stable. Open surgical reduction of inferior ulnar joint is indicated only if reduction is blocked, usually either by the extensor carpi ulnaris tendon or a badly torn fibrocartilage. And that is the only indication for open surgical reduction. Nowadays, the arthroscopic surgeon, we have an arthroscopic surgeon of the wrist who gets in and repairs the fibrocartilage if it comes in the way. Open reduction internal fixation is indicated if large ulnar styloid fragment exists, and fix the styloid and fix it with a tension band or with a screw. And open surgical reduction of inferior ulnar joint indicated if reduction is blocked and suspect interposition of the extensor carpi ulnaris tendon as such. And this is the classical Henry's approach. I want to go into the details. And these are classical case examples. We would call it a type 3. We would, as our classification, we would call it type 3, where the triangular fibrocartilage is completely torn and it is way up. and you would see the appreciation of the displacement of the fracture. But majority of these fractures are transverse fractures, and they can be fixed. All that is the displacement which I was mentioning in a lateral view. It can be displaced volarwards or dorsalwards, depending on the angulation. And this fracture is ideally fixed, as you see, with a single KOA with a 7-hole plate. And here is a situation where a 7-hole plate has been fixed with 2 KOAs which are fixed. What is important is the stability of the inferior radial large joint. And as I rightly mentioned, there is no role for an intramedullary device whatsoever, even with the vogue of intramedullary with the locking nails have come in. But I would say that this is not a fracture which has to be fixed with an intramedullary nail. And here is the situation where you would see a type 3 type of inferior radial large joint. This is a situation where it is not very well fixed, as you see here. It has to be on the radial notch, perfectly reduced. And if it is not reduced, you will have to pull the radius and see that it is anatomically reduced under C-arm, and see that it is fixed with 2 KOAs. And here is it. Oblique fractures are uncommon. If it is oblique fracture, then a neutralization plate with a lax screw is to be fixed. But what is important is to maintain perfect length of the radius. And if there is a styloid process fracture, as you see here, it has to be fixed well. The complications are many. If you as you would appreciate, even with a KOA, there can be an infection. And if there is instability, as you would see, that the inferior radial joint has jut out, and that is a problem which has to be dealt later, either with a Kappanji or any reconstructive procedure which is mentioned. And forearm stiffness, subluxation, non-union and malunion, and the chronic wrist pain, and refracture usually if you try to remove the plate. Gilead fracture variants we do see very, very rarely, but I should mention in the literature, very little is mentioned. It is if there is a fracture of both bones of the forearm with a distal radial large joint is the variant of Gilead fracture. If there is a metadiaphyseal radius fracture with a distal radial large joint injury, it is a variant of Gilead fracture, and with the associated TFCC injury. Here is a situation you would appreciate. There is a fracture of both bones of the forearm with an inferior radial large joint subluxation, and it has to be reduced anatomically and put back into position. And this was the paper which just first mentioned about this particular injury. This also is mentioned as a variant if there is a comminuted or an oblique fracture, where it is very important to maintain the length of the radius and the stability of the inferior radial large joint, as you would see here with a lax screw and with a plate. And here, this is also mentioned as a variant where there is a comminuted fracture of the distal radius with the subluxation of the inferior radial large joint. And you would appreciate, and this was the paper which was mentioned about, a Belgian paper, where the traumatic lesions of the distal radial large joint occur frequently in conjunction with the fracture of the distal radius. And if it is so, then it has to be fixed either with a K-wire or preferably with a plate with the wire across the ulna and the radius to maintain the stability of the inferior radial large joint. And Professor Julie rightly mentioned about the management of Essex leprosity fracture and the importance of the interosseous membrane. One mention about the interosseous membrane is she mentioned about various procedures being undertaken for the instability which is caused by the interosseous membrane as such. But if there is a herniation, the whole herniation of the flexor or the extensor tendon through the interosseous membrane, it becomes very difficult either even with a single or a double suture method which she has mentioned, and it has to be properly reduced back into position, especially so if it is a chronic injury. Well, here is a 59-year-old met with a traffic accident. This is the side swipe injury, and this was the patient. And what is important is the soft tissue which has to be looked into, as Dr. Chaitanya rightly mentioned, and this was a complex injury. almost everything what we have discussed was there, where there was a fracture distal radius, the distal ulna, the fracture both bones of the forearm, and a distal humerus fracture with the shaft of the fracture. So how do you manage it is the question. We waited for 7 days. Once the swelling came down, fracture shaft of the humerus fracture, both bones of the forearm and distal radius were fixed with in one sitting, and an anterolateral approach for the shaft of the humerus, first followed by Henry's approach for the forearm and volar approach for the distal radius. And that is the picture. And after 15 days of waiting, we fixed the lower end of the humerus. This was done nearly about 6 years ago, and this is the distal radius and the distal ulna and the fracture of the ulna and the both bones of the forearm. And this is the 3 years follow, and that is the functional range. What is important is to understand the both bones of the forearm as a triple joint complex of the superior radial ulnar joint, the inferior radial ulnar joint, and the interosseous membrane. What is important is the pronation and the supination movement, which is paramount for our daily function. So to conclude, gentlemen, Gilead fracture is a pleasure to treat for every one of us, orthopedic surgeon, if it is understood well and the length of the radius is maintained with either a 6 or a 7 or a 8-hole plate. More important, however, is the stability of the inferior ulnar joint and the extent of injury of the TFCC. And I again stress that there is no role for intramedullary fixation in this fracture. Even the latest locking forearm nails cannot maintain the stability of this fracture and the inferior ulnar joint. Unlike Monteggia variants, Gilead variants are few and not well illustrated, but has to be looked into. In fracture of the forearm, it is important to assess the proximal and the distal radial ulnar joint, the interosseous membrane injury, and the TFCC injury in particular. Again, I stress the forearm drives and directs the hand, as you see in this. Thank you very much indeed.
Thank you, Professor Shantaram Shetty, sir. Thank you for the elaborate lecture. Do you have any questions from the audience? From the panelists? Yeah.
So now to the variants of Monteggia you told us. So distal radial fractures along with the subluxation or dislocation of inferior ulnar joint, they can be called even as a Colles fracture. They are all metaphyseal injuries. So do we call or do we take that as
I just mentioned about the publications which have come through. Yes. There are 3 publications which have come through as variants of Gilead fracture, variants of Gilead fracture. That's why I mentioned there. Whether we agree with that or not is debatable, as you said. As I said, the classical Gilead fracture is a lower third fracture of the radius, as was described by Ricardo Gilead, with a subluxation or dislocation of the inferior radial ulnar joint. However, if there is a subluxation or TFCC injury with a distal radius fracture, then it can be called a variant. That's why I put this slide.
I have a question. So do you think that the maintaining the radial curvature of the bow very much helps in maintaining the Drg instability?
Yes, that's a very good question. The radius is a radially bowed bone. So even in our initial stages, we were trying to put a lateral plate and did a study with a volar plate as well. But if you really put a longer plate, it really stabilizes the bone. It depends on where exactly. The bowing exactly takes place about almost at the lower third level.
Yes.
But if you put a longer plate, the stability, what is important is anatomical reduction of the fracture. As I told you, majority of these fractures are luckily transverse fractures. And if it is an oblique fracture, it has to be a neutralization plate with a latch screw. Anatomical reduction is a must so that the length of the radius is maintained perfectly.
We have an audience question asking, what is your opinion on a Gilead fracture in a child less than 5 years old?
Yes, we had 2 or 3 patients for the last few years with a They are also many times unstable fracture, which has to be taken into consideration. So we'll have to be careful that anatomical reduction is brought about in these fractures. And you will have to watch the child after ready this fracture every week so that there is no angulation which takes place. And if it is so, it has to be corrected. There is a possibility, especially if there is a posterior angulation, posteriorly displaced Gilead fracture, there is always a tendency for displace in children.
Okay. Do you have any more questions from the panelists? I'll just share my screen.
When to remove DRUJ's wire? That's what somebody's asking.
Pardon?
When to remove DRUJ wire which has been transfixed?
Yeah, that I told you, 4 to 6 weeks time. Usually we remove it in 4 to 6 weeks.
Okay, so I'll just share my screen. So thank you for the lecture. So we'll just go with the case discussion. So I'm presenting the first case I'll be presenting. So this is a 30-year-old construction worker. He had a fall from a 2-story building. So he injured both his limbs, both were closed fractures. So this is X-ray on presentation. The left forearm with wrist and elbow. Dr. Julie Adams, of course, it's a sacroplasty injury. What would be the order of fixation? How do you start fixing these injuries?
Yes, so this patient again shows very, very proximal migration of the radial neck. You see the radial neck is basically right at the capitellum. Even if you didn't see the wrist on this film, you would know that this is worrisome for an Essex Lopresti injury. And then you look at the widely positive ulnar variants and you see that the DRUJ does not look congruent. So in these patients, generally, I will replace the radial head. I don't think that this is going to be something that I can fix. You see one fragment of the radial here, the other fragments are probably there somewhere. And then I would address the distal radial ulnar joint. In general, I'll do an open TFCC repair. And this may be a patient that I might consider a tightrope. This is an acute injury. I have no experience with the double tightrope technique, although it's intriguing. But this is a patient I'd probably do something with the interosseous membrane, either the pronator graft reconstruction or alternatively the tightrope technique.
Thank you. So actually, this patient, in addition, he also had a scaphocapitate syndrome. Of course, it's not visible on the forearm X-ray. So you said you would fix the radial head first, then the TFCC, and then the central band. Am I right, Prof. Julie?
Yeah, that's probably how I would approach it. Generally speaking, these patients are globally unstable longitudinally. Again, you want to be very careful that you're not overstuffing the radial head. That's the biggest concern here. But that would be kind of my order of.
Dr. Chaitanya, so what would you do for the intraosseous apart from the TFCC and the radial head? Would you just pin or do you also reconstruct?
Well, I have no experience of trying to acutely reconstruct it. And I think I would assess the whole thing after restoring my radial head. And as Julie says, after you restore the radial head, you test the stability of the DRUJ. And if the DRUJ appears grossly unstable, then I think it's perfectly reasonable to do an open repair. Since you're going to be making an incision dorsally anyway to address and I don't know that I would call this a scaphocapitate syndrome necessarily. I think this is a form first of a greater arc injury. Scaphocapitate syndrome by definition should have rotation of the capitate proximal pole by 180 degrees, technically speaking. So that's, That not being the case, I would say this is a variant or a stage 2 of the greater arc injury, which has not quite reached perilunate dislocation. So my feeling is, if you're going to be opening it dorsally anyway to fix the scaphoid and the capitate, that's an excellent opportunity to utilize to fix the TFCC. All you have to do is cheat your skin incision one way or the other. And you may not even need to pin the DRUJ. And if you pin the DRUJ, what I tend to do is I put the pin across but take it out from both sides, so that if for any reason the pin were to break, you don't lose the pin and you can pull out the two ends. So,
Dr. Shantaram, you have anything to add?
That's what the pin, as you rightly mentioned, that is what we do in a syndesmotic screw also. Now we go to quadrilateral other side so that even if it breaks, we can remove it from the other end. And well, coming to the, as Dr. Chaitanya writes, there is a fracture of the scaphoid as well here. And coming to the radius, it is almost, I don't think it can be reconstructed and it can be fixed. It is so there are many pieces which are, so it has to be, I would rather replace it and then see the stability of the inferior joint. And as Dr. Chaitanya rightly said, that the ligaments may be repaired or the TFCC may be repaired, depending on the instability of the inferior joint.
I think I find the concept of using the tightrope a very attractive concept. I just haven't had the opportunity to use it. But as Julie pointed out very correctly, that you have to be careful that you don't make the tightrope too tight, because you'll sacrifice rotation then by narrowing the intraosseous space.
Yeah, so I fixed it percutaneously, the scaphoid and the capitate, scaphoid volarly and capitate dorsally. And the radial head, I think I was able to manage to get it together. I'm not sure if it's perfect. And as Dr. Julie said, I did use a tightrope to, first I fixed the radial head, then repair the TFCC and use a tightrope to restore the central band. This was a immediate, I think 1 month post-operative. I think the tightrope is not replicating the exact central band. I think is little in the extreme. So Dr. Julie, what do you think? Is it acceptable? Dr. Julie,
I'm very impressed with your radial head fixation. I'm not sure that I could have. I'm not sure I could have fixed this one, but it looks great with the radial head fixation. And, you know, I love the capitate and the scaphoid, and you've got the DRUJ looks congruent. And, you know, I might have put the tightrope a bit more distal on the radius to try and replicate that that axis of rotation.
So this was actually at 6 weeks after the 2 months from the injury. Now I could find some compression at the DRUJ. I'm not sure if it's because of the tightrope or is it just the view. Actually, the patient is not here. It's a migrant labor. I got it from the WhatsApp. And I think the head, I think most of the neck in my experience, I don't know, it goes for non-union. So is it okay, Dr. Chaitanya, or do you think should have replaced it to begin with?
So I would have replaced it because I'm very worried about the PIN. When you have these complex injuries, you know, a safe zone for safe dissection on the radial neck is just about 4 to 5 centimeters from the capitellum.
Yeah.
So that's number one. Number two, the blood supply of the radial head comes retrograde from the neck. So when you take the radial head out and reassemble it and then put it back in, you're basically putting back a dead piece of bone, right? It's a dysvascular piece of bone. We used to advocate that a long time ago, and some people still do that. I've just gone away from doing that because it is not uncommon for radial necks not to unite. And then if you notice, that empty screw hole in your plate is exactly at the level of the fracture. So these plates predictably fail at that site through that hole because that's a stress riser. Now, all that being said, if you didn't have access to a radial head replacement, an interesting concept which was advocated in the Journal of Shoulder and Elbow, I think a year or two ago, was assembling the radial head on the back table, much like you did, but putting it back as a spacer, not fixing it to the shaft. You understand? So you put it back, accepting the fact that it will not heal. However,
it's a floating head, you mean to say? It's a floating head. What do you mean to
yes.
say?
However, the only caveat I would say is that I don't know that you could apply it here because there's longitudinal instability. That concept was advocated in isolated radial head fractures which are not reconstructable. But again, something to think about.
Yeah. Yes. Okay. So I think what I read one of the articles saying that even this method of fixation, it just acts like a real head processes itself, right? I mean,
yes. Yes.
I'm not sure about the long-term outcomes. I'm not followed up any patient for that long. In your experience, what happens? I mean, if you go for non-union, do you see arthritis happening in the next couple of years, or what exactly is?
See, the thing is, the way I look at it is what's going to happen to the patient and what's going to happen to the X-ray. Yeah. I expect the X-ray, if it's not healing at whatever 6, 8, 12 weeks, I expect the X-ray not to show healing after that. I won't be surprised if the plate failed at that empty hole and the patient may not have any symptoms. So if the patient has symptoms, then you can worry about it. Otherwise, it's merely an X-ray with a failed radial head fixation. And it's done its job of providing you with longitudinal support. That's all.
Dr. Shantaram, sir,
Doctor, I just wanted to ask you a question, Vamsi. That was the Nevo plate, isn't it?
Sorry, sir? No, actually, it's a locally made plate.
You had really brought it down. You had really pulled it down and compressed. If you see the original picture also of your fixation, and it is that you should have really compressed it rather than leaving a gap. And the hole would have been as the Dr. Chaitanya said, those holes could have been avoided if it had really been pulled down and compressed. And
worried about the shortening
position, little shortening to take place so that it compresses. Because you have reconstructed the head very well, as Dr. Julie said, it is unimaginable that we all thought it has to be replaced because it was so much comminuted. And as Dr. Chaitanya said, now the problem is a non-union, and it is likely that the plate may break or the patient will have persistent pain and instability.
Yeah, thanks. So the patient has got a functional range of motion. I think I need to just follow him up further. So now we go for the second case. I think this is Dr. Kannan's case. I think he's here. He will present it himself. Dr. Kannan, you can go.
Thanks a lot, Vamsi. This is an interesting case. This is in the same vein. He presented an acute sexloplasty. This is a chronic sexloplasty missed. So we have a 32-year-old patient. Can you go to the next slide, Vamsi, please? Yeah, so this is a 32-year-old male patient who presented to us 3 months after his index injury and surgery. So he had an ulnar fracture. He had a distal radius fracture, which was fixed with K-wire. And you can see that he's been fixed with some external fixator for the wrist. And he has a radial head dislocation. So this is 3 months after his index procedure and surgery. He also has a pin palsy along with this picture. So I will present the case and then maybe you can give your comments. So we took him up with a lot of skepticism to the OT. So we had kept a radial head replacement. We even thought of shortening the ulna to bring the radial head back. We were thinking of using the palmaris longus or the tightrope. So Vamsi, can you go to the next slide? So I apologize for these images. They're not very clear, but these are the C-arm images. So what we did was we put in a Steeman pin into the radius and we tried pulling it down, but it wouldn't budge, or it reduced a little bit, but it wouldn't reduce completely. So we had to open the radial head. We had to remove the annular ligament from the joint, and then we were able to reduce the radial head. The next slide, Vamsi. So this is the reduction that we got on table. Next slide, Vamsi. So what we did next was we put in 3 wires to stabilize this reduction. And then we have used a tightrope that you can see here. On this image, we have used a normal tightrope to recreate the interosseous membrane. Next slide, Vamsi. So there you can see the circle here. So this is at the end of 2 months. We took off the K wires. We kept the interosseous. This is the tightrope that is seen that was done. The ulna is showing signs of non-union. At this is 5 months from the index surgery, so he probably needs some bone grafting here. And the radial head looks well enlocated right now. We got away with this. We were very skeptical about what to do with this case, but luckily we got away with this. So any thoughts on this and any variation in the management is what we would like to do. Yeah.
You're muted.
I think the reduction looks wonderful now. My initial thought might have been that the ulna, and perhaps I am mistaken because you've got such a nice reduction now. My initial thought might be that the ulna sometimes has a bit of a bow, and if we, especially with slightly more proximal ulna fractures, if the ulna is plated sort of straight, sometimes the radial head bounces out. But that would have been my initial thought. Normally you see that with something that's a bit more proximal, but I have seen it, some ulna fractures that are this distal.
So what do you do on table if the radial head does not reduce? If the radial head does not reduce, what would you go ahead and,
Yeah, so if I was plating the ulna and head remains out, then the first step I would do is make sure that my ulna is anatomic. And sometimes I've gotten in trouble with straight plates with a bowed ulna. And when you realize that the ulna needs to have a bit more bow, then sometimes the radial head will follow back in. And sometimes getting an x-ray of the contralateral forearm or proximal ulna will help you figure out that. It can be very, very challenging. And so this is when I would have thought, do I have my fixation on my ulna correctly? And again, I may be completely wrong. This may be because you did get such a beautiful reduction at the end, but that would be the first thought that I would.
Was the radial head dislocated before the index procedure?
It was missed. This was done somewhere else. So the radial head dislocation was missed. And so we saw him 3 months down the line with a pin palsy and the radial head. I mean, this is the picture we got. But, we saw him 3 months down the line with this kind of a picture.
Yeah, I mean, what you've done is very nice. The only thing is I would have utilized the same opportunity to explore the PIN also.
Yeah.
No, yeah, we did not do that. He didn't have a dense pin palsy, but it was very weak. His extension was very weak. He seems to have recovered.
So the reason to explore the PIN is very simple. Agreed that you're saying it's not dense and he's weak, but basically you're restoring length of a structure which is already compromised and which is very likely to be trapped within the confines of the supinator, which is now going to become much longer because you brought your radial head down. So if nothing else, I would do it to decompress the PIN so as to not impede axonal transport later.
What did you do with the annular ligament? Was it you said the annular ligament was in between? Was it no? You sutured it. Could you suture it back? Was it?
It was just a bunch of fibrotic tissue along with the annular ligament. So we just excised it just enough to be able to push the radial head back, sir. We didn't do any repairs, sir. Yeah.
but it stayed back in position, right?
It stayed back in position. Yes.
I just wanted to ask Dr. Chaitanya, is there a role for distractor, which you mentioned about the mini femoral distractor in the initial stages? Either distractor would help in a rather than putting a Steinman pin and pulling it, rather than femoral distractor, mini femoral distractor to be pulled out, though the Allah is fixed there, but still there is a possibility that it may pop in. Is there a possibility?
Yes, the only concern I have, Professor Shantaram, is that with his pre-existing posterior intraosseous dysfunction, my concern is any forceful maneuvers may adversely affect that. So anything I've done, I would do exactly what they did, gently. I don't think I would have been brave enough to put a Steinman pin in it, but I would have done it manually after seeing the posterior intraosseous nerve, so I know exactly what I'm doing and I can see it with my own two eyes. But I think you got a remarkable reduction. And what happened to his PIN? Did it recover?
It has recovered. It has recovered, almost recovered. He's 3 months post pin removal. So it's 5 months since the surgery, sir. Yeah.
So my feeling is the PIN recovered not so much so because of anything else, but because if you see the radial head's dislocated laterally as well as anteriorly. So I think you actually gained length in the PIN by bringing the radial head back, even though it seems like you lengthened the whole thing because you reduced the radial head from lateral to central. I think you got away with that.
Yes.
Just go the next quick, please. Yeah. So an interesting case. Yeah, sorry. Somebody was saying, Lathesh?
Just Dr. Kannan, hi. I just wanted to ask, did you tackle the distal radial joint?
No, we didn't do anything to the distal radial joint.
Forward. So you just immobilized in any particular?
In supination. Because if at all he gets stiff, we wanted him to get stiff in supination. Yeah.
Oh, this is a more interesting case. I think this scenario is not mentioned even in the literature. Hopeful to get some insights from the senior faculty. So this is a 35-year-old lady. She had a fractured distal radius 8 months ago. So she comes to me now with a fixed supination deformity of the forearm. And this were her X-rays. So apart from the supination, there's no further fix in that position. And the wrist, of course, it's around 30 degrees dorsiflexion and palmar flexion. So these are X-rays. So then, Dr. Chaitanya, you want to comment on this?
Yeah. How is the profundus function?
The profundus, all fingers are fine, sir. Fingers are fine. Nerve and fingers.
How is the ECU and the FCU?
Yeah, ECU means I think so actually there is a deformity in. I don't have the image. There's a deformity in the dorsal ulnar prominence is not that prominent. I mean, it's lost its prominence. So
clearly, she has dislocated her DRUJ.
Yeah.
And my concern is this has been described, if I'm not mistaken, by Ban and Biani.
Oh, yeah, I'll come to the next image. So then you let me know. So what happened? I got our previous X-rays. Okay, I traced it. So this is the X-ray at the time of injury. You can see that this is all neat. The DRUJ is neat, and it just looks like a dorsally displaced fracture. And this set 6 weeks. 6 weeks, you see, it's gone for dislocation. Because she was immobilized in a cast. She says below elbow cast for 6 weeks. And this was the X-ray. I think this X-ray, the doctor initially missed it. So how did this happen? The fracture from here to here, how did this happen? That's something strange. We see a lot of these fractures, but why this particular fracture went for a dislocation? Do you have any insights to this, Dr. Julie?
I don't think it happened. I think it was there all along because your lateral view is not a true lateral view there. I don't think if she had a short arm cast and the elbow was not immobile, I don't see any reason why she should develop that kind of situation. So my feeling is it may have been there all along, and it was just not diagnosed at the time. I find it hard to understand why it should happen while she's in a cast,
Yeah, you can see the amount of the ulnar impaction that's happened eventually. That's because of the collapse. Okay, so now we are here. Now, what do we do next?
This is what I was mentioning as the Gilead variant. So when you miss the inferior radial large joint so grossly, and the type of fracture which you see there, that is described in the literature now, the Gilead variant. So that has to be taken into consideration, and the inferior distal radial large joint has to be taken into consideration and stabilized. And it has to be anatomically reduced. See the displacement of the radius, the ulnar height, the radial height has really come down, and it was wrong to put it in a plaster and treat it.
So you all think that it was there to begin with, and then it was presented later. Okay. So now this is the MRIs and the CT scan. You can see that ECU is out of this thing, and the ulna is almost facing volarly. So how do you do now? What do you do now? So it's 7 months from the injury.
I would do a Kapandi.
Okay. So, Dr. Julie Adams, what do you wish to do? Any of the panelists, anything?
I think that this is one that you may require a dorsal and a volar approach. You look at her initial plane films, and there was not a huge deformity in the radius. So I'm not sure that the bony abnormality is the problem. I could be mistaken, but I think that there's a soft tissue issue unless there's something further on in the forearm that we're not seeing.
So you would still go for the reconstruction? Is that what you mean to say? You still want to try to put the joint back? Is that what you're saying?
Yeah. How far out is she?
So she's 35.
How far from her injury is she?
8 months. 8 months.
8 months. Yeah. I had a patient who had a volar dislocation without a fracture of her ulna that was missed for about 6 months. And, my concern was how arthritic she would be. But I don't see any soft tissue in her position. We worry about the ECU or the FCU getting interposed and making it hard to get that out. But I think that I would try and reconstruct this.
Okay. So, I think, I went for the Sock-Kapanji procedure because I was not sure if I could restore the range of motion. But unlike the traditional Sock-Kapanji, I had to go volarly than the dorsally, and I went with the Sock-Kapanji, and I think the PQ was the taut. Still, I think she's yet to regain the pronation. She's able to get the forearm to the mid-prone, but not complete pronation yet. She's still on therapy. So we have time for the next case. I think, Doctor, should we stop the session here? Yeah.
I have to jump onto another Zoom call.
Sure. So we'll end the session. I think Dr. Satish sir is here. Dr. Satish sir.
Thank you, Chaitanya. Thank you, Julie.
Okay. Thank you all. It was a great session. We learned a lot. Thank you, sir. Thank you, Chaitanya sir. Thank you, Shantaram Shetty sir. Thank you, Julie.
Thanks so much for having me. This has been wonderful.
Thank you.
I want to wish to thank Alembic Pharma for sponsoring this event, and OrthoTV for streaming this all over the channels. Thank you all. Yeah. Good night.
Take care. Thanks, everyone. Bye.
Thank you.